So what we're going to do is we're going to get an EEG on Shane, and we're going to turn that into a quantitative EEG. So what I like to start out with are these little alcohol prep pads. You can certainly substitute a cotton ball and some 70% isopropyl alcohol. The next thing I'm going to be using here is New Prep. New Prep is a pumice-based scrub, and I'm going to put about a pea-sized amount here on my alcohol swab. I like to use my thumb just to blend it in a bit, and then I let the patient know, I'm going to be touching your earlobes and your forehead. This is a prepping for the EEG. And so some clinicians use the back side of the earlobes. I tend to use the front sides of the earlobes, and you just want to run over them a few times. I like to be gentle with the hair and just get the whole forehead. The point being to remove any oils, any skin cells, any dirt that might be in the way of the recording process. Next thing I'm going to use are these little foam discs. They have adhesive sides on the back. Some clinicians use them, some clinicians do not. And so they're going to go on the frontal electrodes of the EEG cap. The EEG cap's going to have a tag in the back, in case you get confused which is the back side and which is the front side. What I'm going to do is I'm going to take these little foam discs and I'm going to place them around the front electrodes. What this will do is it's going to prevent slipping of the cap should Shane move or thrash about, which happens with some clients, unfortunately, particularly developmental disorders and things like that. Now, when I place the cap on, what I like to do is put all 10 fingers in it. And the point of this is to stretch it nice and big. And so from pinky to thumb, you stretch it as wide as you can. And then what this allows for me to do, get this ear electrode straight, what this allows for me to do is to slip it onto Shane's head in such a way that's pretty smooth, right? Making sure that it's centered, take a look at me. And we want the front two electrodes to be nice and centered, pretty close. Hang on one second. Okay. So the next step here is we're going to plug in our cap to the impedance meter. So I'm going to go ahead and stick this into the Q-check and jump right into neurofield. When the system comes on, we're going to move into the Q-check, which is the impedance meter, and I'm going to go ahead and start the Q-check. I'm going to pull this screen to my extended desktop just so that it's easier to see. There we go. So now what we have here is we have red, which is going to show the contact voltages, and what I'm going to aim to do here is to cap up Shane pretty quickly. The point of this is that you don't have to take half an hour to cap up a client. So what we have here is a blunt-tipped syringe, and a lot of times I'll tell patients in the beginning, this is a blunt-tip needle, it can't pierce your skin. What I'm going to be doing is injecting a salt-impregnated paste, this is electrode gel, into the EEG cap, building a connection between the electrodes and your scalp so we can get a reading of what's going on. I'm going to start out with the ear clips by placing about a pea-sized amount of gel into the ear clip, and I'm going to clip it on the areas that I've just prepped. And what we should see is that the impedance of the reference drops. So this next step is hopefully of most use, which is explaining the three fundamental pieces of getting good impedance in an EEG. And this is what's going to distinguish between the person that's going to take 30 minutes to get the EEG and the person that's going to take 5 minutes. Well, 5 minutes to set up. So I'm going to start out with the ground electrode, which is this electrode. Its center is closest to the the front electrodes, and when I do this, what I'm doing is I'm lifting up the electrode with my pincher fingers. I'm holding my syringe with my thumb on the plunger, and so I'm squirting just a touch of gel. And the three things here are pressure, speed, and then if you'll notice the end of my syringe I'm making a letter O with, and I'm moving pretty quick. So it's a strange sensation, not necessarily the most comfortable, but the point here is to drop the impedances rather quickly, as you can see that I'm doing over here. So let's see how long it takes me to move through Shane's entire head. And again, what I'm doing here is I'm using my pincher fingers, lifting up that electrode, squeezing just a touch of gel, and then I allow the electrode to drop back down. And you'll notice the entire time I'm keeping both of my hands involved in the process. I'll notice sometimes clinicians want to just take away the hand that holds the electrode, but it stabilizes. And so I lift and I let go, and again, pressure, speed, and what I call the swizzle, which is making that big O with the tip of the syringe. And so over here my impedance meter is showing me my impedance, or how much resistance there is between the electrodes and the person's scalp. The point of this, of course, is to get as little artifactual or false data in the real electrochemical firings of the brain. Right? And so now, I've just capped him. This is a pretty average sort of run through. I can see there's a few reds here. There's a few channels that I'm going to need to fix. And so one of them is T6. One of them is O2. P3, P4. C3. And if I want to be a perfectionist, what I'm going to do is drop the impedances all the way down so that everything is underneath 50 microvolts square. And that's when every cell is turning green. How are you doing, Shane?
Good. So good.
Perfect. There's 3 more electrodes and then we're done. P4, T4, F8. Once all of our impedances are low, I'm going to go ahead and stop the Q check. And close the impedance meter. Now at this point what I'm going to do is I'm going to take the cap and transition it to my differential amplifier, and I'm going to turn off my impedance meter. I'm going to go ahead and close Q check, and let's pull neurofield over to the screen. And so I'm going to enter my new patient information. Okay, so what I've done is I've grabbed my fob. What this is going to let me do is use the neurofield system to record the EEG. So next thing is I'm going to enter how long I want this recording to be. What I'm going to enter is 10. Ideally we're going to want 10 minutes of eyes open and 10 minutes of eyes closed EEG. That's a standard that's been set, and that which is the amount of time recorded allowed in United States Court of Law, should an EEG recording ever go there. I'm going to go ahead and hit record. And we're off to the races. What I'm going to do here is I'm going to open up an EEG recording software, and there's lots of different softwares that you can record from. I'm going to enter my patient. All right, and so what we have here is our recording. Now that the recording's going, I'm going to go ahead and hit the record button. This This is a script that I like to give to all of my patients when we're getting the initial EEG. So Shane, what I'd like for you to do now is to direct your gaze towards a spot on the ground. Go ahead and relax the muscles around your eyes. Soften your forehead, relax your jaw. Allow for your tongue to slide away from the roof of your mouth and allow your teeth to slightly part. And assuring that we have a good, clean EEG recording, we're off to the races. And I'll say now what we're going to do is we're going to remain silent for 10 minutes. I will give you the countdown as we move along. What I encourage you to do is to memorize your own script. Have your own script wrote in your mind and memorize it so that every single time, even if this is your patient's 50th recording, you give them the same script. Then they know what to expect. Some clinicians like to put a spot on the floor or something particular for them to gaze at. That's up to you as the clinician. I find that allowing the client to sort of have an open, focused gaze on a spot on the ground prevents certain artifacts from happening. So now we wait, and I often will just give a minute-by-minute countdown, sometimes every couple of minutes depending on my patient. So we're about a minute and a half in. Shane, it's going to be about 8.5 more minutes of recording. Great, so now what I'm going to do is, got my eyes open EEG, time for our eyes closed EEG. So I'm going to say now, as I hit start, Shane starts out with his eyes open. And here are my instructions. All right, Shane, now we're going to do our eyes closed EEG. What I'd like you to do is close your eyes, relax the muscles around your eyes, soften your forehead, relax your jaw, allow your tongue to slide away from the roof of your mouth, and allow your teeth to slightly part. And now we're in his eyes closed EEG. One of the things that you'll often notice right out the gate is the alpha waveform that's going to move through at the occipital lobes. And this is one of the fundamental things that people begin to read EEG with, because it's an easy waveform to count, it's sinusoidal, and in this case we can count Shane's alpha peak frequency. And it looks like he's about a 9.5 10 Hz alpha peak frequency, which is considered the Goldilocks range. Not too fast, not too slow. And again, the alpha peak frequency is his processing rate, how quickly he's going to be uploading and downloading data. So the next piece is important, albeit underwhelming, which is removing the cap properly. The point of this is we don't want to damage the cap, we don't want to break the wires. So with Shane, what I'm going to do first is remove the ear clips, and I like to say I take them off like you would take off a clip-on earring. You just pull it right off, and then when you take the cap off, you're going to use the main cords as an assistant to help you sort of tease the cap off. And if you're using the sponge discs, what you're going to want to do is to softly remove the adhesive side from the scalp. What that does is it prevents any breaking of any wires. We're not pulling the cap back, but we're simply teasing it off the client's head. Never let the client take their own cap off. And now the final piece is going to be just getting as much gel off of the patient as possible. And so what I'm going to do here is just use a dry towel, and I think that our job is to leave them looking as good as possible with gel in their hair. And so what I'll usually say to the patient is, what I'm going to do is fix this so you won't look as though you've just had a brain map, but you will probably feel the gel in your hair today. Don't pick at it, because it tends to flake and get white when we do that. And so if you don't pick at it, no one's going to know, and you'll be fine.